early-stage renal disease. Pregnancy complications. Preeclampsia. Principle of management. 1. Spontaneous resolution of reflux is very common. 2. High-grade reflux is less likely to resolve spontaneously. 3. Sterile reflux is benign. 4. Extended use of prophylactic antibiotics is benign. 5. The success rate with surgical correction is very high. Treatment option: medical antibiotic prophylaxis. Open surgery, urethral reimplantation. Intravesical, Cohen, Politano, Leadbetter, extravesical, Litgregoire, Detriusarapi, endoscopic injection. Laparoscopy as applied to correction of reflux. Medical treatment is indicated in cases of low-grade vesicitral reflux without outlet obstruction or other abnormality. Good patient compliance is necessary. Antibiotic is a conservative treatment. Aim is to prevent urinary tract infections, thereby protecting the kidney until spontaneous solution occurs. Is a symptomatic treatment, there is not cured. Daily antibiotic treatment to reduce the risk of urinary tract infection. UTI, non-curative, therapy is continued until reflux resolves. Relies on long-term patient compliance. Micturition cystoarthrograms, MCUGs, are periodically required to ascertain the need for continued therapy. Advantages: conservative approach may be preferred by patients. Low risk of serious adverse events. Lack of need for surgery. No waiting time or anesthesia. No operating room costs. Disadvantages: conservative approach may need to be continued for many years. Breakthrough UTI: 5-year infection rates above 40% have been reported. Risk of antibiotic resistance. There is not cured. Poor long-term compliance. Possible difficulties with administration. Need to crush tablets for infants. Unpleasant taste may discourage children from taking their medication. Risk of adverse events. Continued need for monitoring. Regular MCUG assessments. Approximately 20–40% of patients will develop UTIs while on antibiotic prophylaxis for 5 years. Infections experienced during ongoing antibiotic prophylaxis can result from lack of patient compliance with the treatment regimen. Resistant bacterial strains. Missed doses leave the patient open to UTIs. Exacerbate the risk of antibiotic resistance. Poor compliance is more likely in younger children during long-term antibiotic use. Antibiotics: trimethoprim, sulfamethoxazole, TMP/SMX, nitrofurantoin sulfamethoxazole, amoxicillin. Cephalosporins, for example cefalothin, 1st generation, sulfixime, 3rd generation. Side effects: most commonly gastrointestinal upset, nausea, vomiting. The occurrence of adverse events makes the treatment unpleasant. May further reduce compliance. Some children may suffer an allergic reaction to the antibiotic, most commonly a skin rash. Long-term outcomes: overall spontaneous resolution rates 16–49% after 4–5 years, dependent on reflux grade. Resolution more likely with lower grades of reflux. Rate of resolution decreases over time for children with grade I of reflux. 48% will require treatment for 10 years. New renal scars have been reported in up to 22% of patients. Surgery: 1. Indicated in patients with high-grade primary reflux, grades 4 and 5, to those with low-pressure reflux and significant hydrota, and patients in whom medical management has failed. 3. Persistence of reflux after 3 to 4 years of antibiotic prophylaxis. 4. Multiple breakthrough infections, new or increased renal scarring, deterioration of renal function. 5. And non-compliance with medication. Reimplantation of the ureters into the bladder wall. Intravesical and extravesical techniques. Major surgical procedure requiring hospitalization. Aim: to increase the submucosal length of the distal ureter to restore flap valve function. Catheterization usually undertaken overnight following the procedure. Surgical principles: 1. Exclusion of causes of secondary VA. 2. Adequate mobilization of the distal ureter without tension or damage to its delicate blood supply. 3. Creation of a submucosal tunnel that is generous in caliber and satisfies the 5:1 ratio of length to width. 4. Attention to the entry point of the ureter into the bladder, hiatus, the direction of the submucosal tunnel, and the ureteromucosal anastomosis to prevent stenosis, angulation, or twisting of the ureter. 5. Attention to the muscular backing of the ureter to achieve an effective anti-reflux mechanism. 6. Gentle handling of the bladder to reduce postoperative hematuria and bladder spasms. Advantage, suitable for use in high-risk patients, for example high-grade reflux. Possible avoidance of the need for follow-up McCUG. High success rates have led to surgeons not undertaking routine post-operative McCUG. Disadvantages, risk of adverse events and some significant complications: obstruction, hematoma, infection, persistent reflux. Contralateral reflux requires 2-3 hours operating room time, hospital stay, generally 1-2 days. Post-operative pain complication: 1. Persistent, transient, contralateral reflux. 2. Postoperative ureteral obstruction. 3. Hematuria. 4. Urosepsis. 5. Anuria. Outcome, cure rates 95% for reflux grades IV in patients with grade V reflux. The cure rate decreases to 80–90%. Significant reduction in febrile utis. Nevertheless, overall occurrence of UTI is similar to that with antibiotic prophylaxis. New renal scarring affects typical around 20% of patients during 4–5 years of post-operative follow-up. Intravesical procedures Politano and Leadbetter bring the ureter in through a new hiatus superior to the original insertion. A submucosal tunnel is created in the direction of the trigone, medial to the original orifice. Glenn and Anderson described their technique of ureteral reimplantation. By using the same hiatus and advancing the ureter distally toward the bladder neck, Cohen's technique, by directing the tunnel across the trigone toward the contralateral bladder wall. Extravesical procedures Litgregor/Dietriusa-Rappi technique. Endoscopic treatment technique first investigated 20 years ago. Rationale: open surgery entailed hospitalization for =1 week. Surgery not free from complications. Subureteral transurethral injection, support under the refluxing ureteric orifice. Improved valve mechanism. Fixation of the distal ureter at the ureterovesical junction. Increased submucosal tunnel length. Advantages like open surgery, a curative treatment. Outpatient procedure usually, no need for hospitalization. 30-minute operating room time. Efficacy rates can approach those with open surgery, depending on reflux grade, injection technique and experience with the procedure. Disadvantages: cure is generally less certain than with open surgery. Possible need for repeat treatments. Anesthesia still required. Outcome: overall cure rates approximately 70–80%. Cure rates potentially affected by reflux severity, grade, surgeon's experience. Injection technique. Need to consider long-term durability of treatment. Response agents, non-autologous materials. Polytetrafluoroethylene, cross-linked bovine collagen polydimethylsiloxane. Dextronomer hyaluronic copolymer, deflux, autologous materials. Chondrocytes. Fat collagen. Muscle deflux, easily injectable, viscous gel made from 2 polysaccharides. Non-animal stabilized hyaluronic acid. Nasher, Dextronomer microspheres, 80–250 μm. Hyaluronic acid exists in all living organisms. Low potential for hypersensitivity reactions. 1%. Fully biodegradable. Used extensively in eye surgery and joint injections. Hyaluronic acid is produced using cultured bacteria. Limited potential for allergic reaction. The hyaluronic acid undergoes a stabilization process. Increased durability. Dextronomer microspheres. Polymer of glucose, cross-linked dextran, microspheres 80–250 μm in diameter. The laparoscopic approach. The Gil-Vernet procedure,